Hello. Today we will talk about inflammatory bowel diseases. Fundamentally, there are two types of this disease, ulcerative colitis and Crohn's disease. And maybe the best way to understand these diseases is to get to know a typical patient on their journey from the onset of symptoms until adequate disease control is achieved. Our patient is 20 years of age. She is of a shy and reserved nature. Her stomach has always been a weak spot. She never ate much when she was small, and her stomach would always react to different stimuli. Colds, changes in environment, changes in food, stressful situations. She would often lose her appetite, have abdominal pain, and diarrhea. This all resulted from the precautionary, perhaps excessive approach of her parents. She noticed the onset of her true disease while she was under a lot of stress, preparing for a few difficult exams. Studying at night, she slept less and was on an inadequate diet. In the beginning, she had painful abdominal cramps and occasionally a watery stool. She had a weak appetite, felt unwell in general, exhausted and frail. Initially, she believed it was due to the stressful period and temporary difficulties, in light of her already sensitive stomach. However, the condition worsened, the pains were more frequent and lasted longer. She felt nauseous, lost weight, and occasionally there was an increase in body temperature. Her parents were very worried and somehow managed to convince her to contact a general practitioner. The general practitioner prescribed medicine to relieve the health difficulties and recommended more frequent meals and rest. However, despite changing her diet and using the prescribed therapy, the symptoms did not disappear, but in fact worsened. After another checkup, the doctor suggests laboratory tests. The results showed anemia, low iron values, an elevated sedimentation rate, and the so-called C-reactive protein. The general practitioner suspects inflammatory bowel diseases and refers her to a specialist. After inspecting the results and gathering the data on the family medical history and the psychological characteristics of the patient, the specialist informed the patient that it is most probably inflammatory bowel disease and that further laboratory and endoscopic tests need to be conducted. During this time, the patient is usually frightened and confused, so it is important to give them as much information about the disease and future treatment. Inflammatory bowel diseases are chronic, non-specific, immunologically conditioned diseases of predominantly the digestive tract, intestine, and have an unknown cause. They are characterized by periods of relapse and then remission of symptoms and discomfort, and which, if not treated or treated inadequately, lead to complications, permanent damage to the digestive tract, and disability. These diseases mostly occur in young people, usually between the age of 20 and 40, rarely occurring with the elderly, and more recently prevalent with children. They are more likely to occur in developed countries, Western Europe and the US, which can point to some factors in lifestyle or nutrition that can take part in their onset. The factors that cause these diseases are still unknown, but it is believed that a synergy of several aspects and a complex mechanism lead to their occurrence. A genetic predisposition causes an altered, overemphasized immune response. Such an immune mechanism reacts excessively to common stimuli. It is thought primarily due to food ingredients, intestinal bacteria, and other external factors, and triggers an uncontrolled inflammatory process that does not stop as it does with healthy individuals. These immunological mechanisms are guided by various molecules and mediators, and the goal is to put them under control with an appropriate therapy. Crohn's disease and ulcerative colitis are inflammatory bowel diseases. Both diseases develop in a similar way and have a similar clinical course. The manifestation of the inflammatory process in the intestines is also similar, so that sometimes, especially at the beginning, it is difficult to clearly separate and define them. Ulcerative colitis affects only the mucosa of the colon, where the rectum is always affected, and Crohn's disease can affect all the segments of the digestive tract, from the mouth to the anus. Moreover, with Crohn's disease, The inflammatory process affects all the layers of the intestinal tissue, and thus is often further complicated. By spreading of the inflammation through the wall, out of the intestines, inflammatory collections are formed in the stomach, openings can appear, channels between the intestinal creases or other organs, and skin fistulas, or narrowing of the intestine. In ulcerative colitis, inflammation affects only the surface layer of the colon, mucosa, and thus this disease, to a degree, is less severe compared to Crohn's disease. Often with these diseases, there can be manifestations outside of the bowels. The inflammatory process can affect other systems and organs, usually bones, joints, liver, gallbladder, skin, or eyes. Such forms of the disease are more severe. In order to reach a diagnosis, the previously conducted tests are carried out in an ambulatory manner. Considering the duration of the symptoms and the need to start treatment as soon as possible, if it is proven that the presence of an inflammatory bowel disease exists, the patient will be hospitalized. This is generally the safest option. We then conduct additional laboratory tests, check the stool, and perform an endoscopy. We examine the stool sample in order to exclude the possibility of a possible intestinal infection, but also to check a very important parameter called calprotectin. The increased values of this parameter indicate inflammation in the intestine, and its analysis is always conducted for further monitoring, letting us know the degree of inflammation. We can't discuss curing inflammatory bowel diseases as we do with other diseases, in a narrow sense. With an adequate approach related to the characteristics of the disease at the moment of diagnosis and the assessment of severity, we can immediately begin with appropriate therapy aimed at putting the inflammatory process under control and keeping it in remission. This, therefore, leads to the withdrawal of the symptoms and the normalization of the findings. With this approach, the disease can be controlled for a long time and maintained without further deterioration or damage to the intestines. Today, there is even medication that can lead to mucosal healing, which we consider the main goal of the treatment. For the success of the treatment, it is most important that we detect the disease as early as possible, before the occurrence of severe damage to the bowels, and assess the so-called risk factors that can determine a more unfavorable and more difficult course of the disease. A colonoscopy is an endoscopic examination of the colon and end of the small intestine and belongs to diagnostic procedures. Before the examination, the patient should prepare by clearing the bowel, which is the main precondition for it to be performed adequately. The examination is performed with a short-term anesthesia, an analgesic sedative, which protects patients from feeling any pain or discomfort. It implies the insertion of an optical instrument, an endoscope, through the anus and along the colon to observe the intestinal mucosa. It is often said that this method is the golden standard for the diagnosis of inflammatory bowel diseases. It allows us to directly observe intestinal mucosa, the degree of inflammation, which segments are affected, and how damaged it is. Above all, it allows us to take a sample of the mucosa for histological analysis and confirmation of the diagnosis. The image of the mucosa informs us whether it is ulcerative colitis or Crohn's disease, depending on where the inflammation and impairment is present. But when Crohn's disease is present only in the colon, the image may be identical to an ulcerative colitis. Then, only a histological analysis can help distinguish between these diseases. The patient is informed that she has Crohn's disease and is put on a corticosteroid treatment, after which she quickly feels an improvement. The disease was most likely present for a much longer time, so the long-term stomach sensitivity was actually a disease, only in a milder form, hidden, until its activity clearly led to a diagnosis. In some cases, the disease can occur rapidly in patients who have previously never experienced any abdominal difficulties, usually when it is already complicated and manifested through the narrowing of the bowel or by the appearance of pus collections in the stomach. Knowing that the immune mechanism is responsible for inflammation, the common therapy for treating these diseases are drugs that reduce the activity of the immune system and block it. The disease should first be put into so-called remission by easing the difficulties and inflammation, and then maintaining the remission state over a longer period of time. The common drugs usually given as the first line of defense are corticosteroids, administered orally or intravenously in higher doses if the disease is more severe. Corticosteroids usually quickly improve symptoms and laboratory findings, and based on the response rate to therapy, the activity of the disease is estimated. The use of corticosteroids, however, are accompanied by side effects. The onset of acne on skin, changes in mood, increased appetite and weight gain, sleep inversion, which withdraw with a discontinuation of therapy. Patients that don't respond to therapy are put on stronger medication and in some cases must undergo surgical treatment. With corticosteroids, other medications should be prescribed to protect the mucosa of the stomach and vitamin D due to increased bone degradation caused by steroids. Corticosteroids are not to be used over a long period of time due to their side effects and the fact that they cause hormonal shifts of the adrenal gland. We assess the response after 2 to 3 weeks and then consider reducing the dose or discontinuing use if a positive effect is achieved. If the response is good, with reduced symptoms and normalized laboratory parameters, we would continue the treatment with immunosuppressive drugs. These drugs have a better chance at suppressing the immune system and better control of inflammation. They are used over a long period of time, so special attention should be given to possible intolerance or side effects during use. Intolerance to these drugs is most often congenital, genetic, and can have a toxic effect on the functioning of the liver and bone marrow. The toxicity is assessed either by genetic testing or indirectly by monitoring the laboratory parameters of the liver and bone marrow functions. This is performed immediately after introducing the drug and monitored weekly during the first month of administration. The most common side effects are abdominal pains, nausea, joint or muscle pain, and hair loss. However, more severe manifestations can occur, such as pancreatitis. The occurrence of undesired effects or toxicity prevents the continued use of these drugs. The most commonly used are azathioprine or methotrexate. The azathioprine drug takes effect within 1 month, but the true effects occur after 3. Until then, we usually use a lower dose of corticosteroids to avoid adverse effects. The common therapy for the treatment of ulcerative colitis are mesalazine drugs. These drugs reduce inflammation and do not operate via the immune mechanism. 2/3 of patients with ulcerative colitis are successfully treated with these drugs if they are taken regularly, even when the disease is in remission for a long period of time. Many patients stop taking the medication on their own because their condition is in remission and they feel they have been cured. However, as a rule, discontinuation of therapy very quickly leads to flare-ups. Usually, pills and compounds that are taken locally are combined. Therapeutic enemas, foams, or suppositories, which act locally by coating and regenerating the rectal and descending colon mucosa. Mesalazine compounds are successful even if there is a need for corticosteroids at the beginning of treatment, as they are a maintenance therapy for most patients. If the disease frequently progresses or is permanently active and requires repeated steroid use to reduce the inflammation, the patient is switched to immunosuppressive agents or later to biological therapy. Even then, mesalazine drugs, especially local ones, are used as part of therapy as they contribute to the reduction of inflammation. We mentioned that these diseases are characterized by a chronic course with periods of relapse and then remission of the disease. Such exacerbations can occur with or without a provoking factor, but most commonly occur if patients stop taking their medication. If there is relief from discomfort, the prescribed therapy should be continued and regular checkups should be carried out. Attention should be given to possible side effects of the drugs, learning to evaluate whether complications occur due to a relapse or some other factor. Even during periods of remission, patients can, in the long run, feel a loss of appetite, feel sick, have mood swings, anxiety, and experience struggles by the general burden of the disease. Since these are young people, taking into account the symptoms of the disease, we can often say that their quality of life is significantly disturbed. They are withdrawn, avoid going out, avoid social and intimate relationships, are absent from school or work, especially due to frequent relapses of the disease, and the need for repeated intensive therapy, analysis, and hospitalization. That is why it is of utmost importance to understand the disease, maintain good communication with physicians and healthcare personnel, family members, and environment. These young people should not differ from the rest of the population, regardless of their disease. When the disease is in remission, it is often followed by an iron deficiency anemia for a long period of time. This is due to several reasons: the activity of the disease, poor appetite, low iron intake, loss and weaker absorption of iron due to the damaged mucous membrane. In that case, mainly, patients have to take iron supplements. Sometimes vitamin deficiency is present, most commonly vitamin D. Often, additional antibiotics are used to control intestinal flora, probiotics, and medication for diarrhea and cramps. This is the so-called symptomatic therapy. Nutrition should not play a key factor in disease control. During the remission period, food does not have an active effect and patients should not deviate from their usual diet. During periods of relapse, and depending on the nature of the discomfort, an appropriate dietary regime is applied to ease the damaged mucous membrane of the bowel. Frequent use of vitamin compounds and supplements are preferred, especially if there is a deficiency of vitamins and minerals. Despite the fact that therapy controls symptoms and that patients feel well, the disease is active and can lead to progressive damage. This can be indicated by sustained elevated levels of calprotectin and other inflammatory parameters or frequent relapses. The occurrence of severe abdominal pain, diarrhea, fever, weight loss, and loss of appetite may indicate a relapse in addition to the usual more mild symptoms that patients may have during a remission phase or during a phase of functional hypersensitivity and reactiveness of the stomach. During periods of relapse, symptoms related to extraintestinal manifestations may occur, for example, pain and inflammation of the joints, changes in skin in the form of inflammatory collections or psoriasis, and inflammatory changes in the eyes. This phenomenon indicates the development of a more severe form and a more pronounced exacerbation of the disease. Sometimes symptoms of a more complicated disease manifest, symptoms due to the narrowing of the bowel, pain, vomiting, absence of the stool and gases, the appearance of pus and inflammatory collections in the abdomen, or forming of a fistula. In all these cases, an assessment of the findings and the activity of the disease is necessary to decide whether to continue the medicamentousness treatment or to turn to surgical treatment. The surgical treatment of Crohn's disease is carried out in the case of a complicated disease, with the occurrence of an abscess, a narrowing, stenosis of the intestine, a fistula, or in the case of severe activity that cannot be controlled by drugs and can potentially jeopardize the patient. Usually, resections of the affected area of the bowel are carried out and the abscess is drained. Sometimes, if the resection or removal of the colon is extensive, a permanent stoma is formed, a sachet that disrupts the quality of life of the diseased person. Surgical treatment of Crohn's disease does not lead to its healing. After surgery, it is necessary to continue with therapy, usually with stronger immunosuppression, taking into account that we are already dealing with a complicated disease. Surgical treatment of ulcerative colitis implies a complete removal of the colon and rectum. The permanent lifelong stoma or pouch is formed. A pouch is a reservoir reconstructed from the third part of the small intestine so that the patient does not require a stoma. Biological therapy is the most effective medicamentous therapy in the treatment of inflammatory bowel disease today. It is made of antibodies against different mediators of inflammation, molecules that promote the inflammatory process. It is the only therapy that can stop the progression of the disease and lead to the healing of the intestinal mucosa, which is the main goal of treatment. It is applied to patients with an active disease which require repeated administration of corticosteroids, the so-called steroid-dependent disease, and in which the use of immunosuppressors has not led to the control of the activity or has lost this control over time. Also, it is applied in more complicated forms of the disease, for example, those with extraintestinal manifestations or the presence of a fistula, as the most severe form. There are different types of biological therapy drugs with different mechanisms of action. Some of them have systematic action, affecting the whole body, and some of them are more specific, acting only on the gastrointestinal tract. Biological therapy is applied periodically according to a clearly defined schedule. It is important to know that patients can receive new drugs even during trial stages, within a number of clinical studies that are being conducted, which is a great advantage in treatment options. Considering biological agents are strong immunosuppressors and make patients more sensitive to different infections, before their use it is necessary to exclude the presence of serious systematic infections and diseases, such as tuberculosis, hepatitis, HIV, as well as implement vaccinations against seasonal and epidemic diseases. Given the severity of the disease and possible manifestations, at this stage it is most important to understand how to deal with the disease and how to maintain a good quality of life. The Patients Association is a very important organization. Associations are present all over the world and their significance is recognized in several different aspects. Through good communication with physicians and nurses, and through educational and other activities, the association raises awareness about these diseases and the difficulties encountered by those affected. At the same time, it is recognized by official institutions that work together to protect the rights and improve the quality of life of patients as well as enable access to adequate treatment. We try to motivate all our patients to plan a family and pregnancy if they choose to. Before planning pregnancy, the disease should be introduced and maintained in a remission phase. If conception occurs while the disease is in remission, the outcome of the pregnancy will be no different than that in a healthy individual, and the disease will not progress. All drugs are generally safe during pregnancy for both the mother and fetus and are not harmful during breastfeeding, except methotrexate, which is contraindicated. Therefore, therapy is not interrupted during pregnancy. When it comes to inheriting the disease, it is somewhat higher but not significantly, as the risk of a child inheriting IBD is present only if both parents are affected. With an appropriate therapy, regular checkups, and proper management of the disease, our patient has established a good quality of life. She has graduated from college and has a successful career. She is in a romantic relationship and, of course, planning a family.